Thank you, organizers and colleagues. It's a pleasure to be here, and nice audience too. I've been given the honor of being the dwarf among the giants, and I will give you an appetizer of what the real guys can tell you by briefly introducing some of the key aspects of OCT angiography and how it may look together with fluorescein and ICG angiography. So you're familiar now with type 1 neovascularization, and here you see an OCT on-fast angiogram down here to the lower right, and around it you have fluorescein angiograms that show various phases of the angiogram with leakage and patterns of neovascularization, where you see mostly the tufts around the periphery of where they are. And whereas with the OCT angiogram, you have a lot more details, and you see the whole pattern of the branching, and you get a good impression of where in the middle there's probably a feeder vessel. And this is the same image again, and down there below you have the structural OCT, and the two red lines indicate where the image was taken from. That is the OCT angiogram to the top right. So OCT angiography is layer selective. That's a key component to understanding what you're seeing on an OCT angiogram. You can build instruments that automatically do segmentation of the retina and the choroid and present you with a qualified guess about where you have the inner capillaries of the retina, the outer capillaries of the retina, the neovascularization, if there is a choroidal neovascularization, the choriocapillaries and the deeper layers of the choroid. And then when the anatomy begins to become abnormal, it gets more and more challenging for the algorithms to follow the perturbed lines of the retina, especially the outer retina. And this is where currently there may be a need for you to step in and manually trace where you, with your brain pattern recognition system, can identify the remains of a pigment epithelium layer. And this means that there is a lot of interaction here, and I can assure you that the people who pioneered this technique and who have described all the essential features, they have done OCT themselves. So am I right, Rick? You're sitting by the machine, you're just not letting a bunch of nurses do the examinations, because you have to really take a good look at what is happening, adjust the scan, do another one, and learn as you scan. And so here is another type of type 1 neovascularization. And why do we keep talking about type 1? Because fluorescein angiography is doing pretty well with neovascularizations that are in front of the retinal pigment epithelium. It is the neovascularizations that are behind the retina, behind the retinal pigment epithelium, that are particularly difficult to discern on an angiogram, especially a fluorescein angiogram, where you see vague patterns, as on the two top images. And on figure C, you see a vague late phase outline produced by profuse leakage underneath the pigment epithelium. But when you come to D, you see a very sharp outline of the new vessels behind the retinal pigment epithelium. And at the bottom, you have the structural cross-sectional OCT that shows you that here we have some features that are compatible with central serous chorioretinopathy. There's a serous detachment of the neurosensory retina, and there's a very shallow undulating detachment of the retinal pigment epithelium, and it's right there in that very, very thin layer that you have the vessels shown on the OCT on image section D. Now, when you have a vascularized PED, which means a type 1 neovascularization that elevates the retinal pigment epithelium to a very gross extent compared to what we saw before, then you can find examples where en-face OCT is challenged by either the structural characteristics of the CNV or by the difficulty in penetrating down to where the new vessels are. So when you look at the lower image, you can see green lines that define which layer, which distorted layer has been selected for display in section D as a presumed neovascularization or at least a layer of interest. And you can then start running it up and down and trying to get a three-dimensional impression, alternative visualizations of the structures down there, and you may also want to supplement this with an indocyanine green angiography to see if you can, that makes you wiser. So again, there is a whole lot of interaction between the different modalities that you can now use to examine the retina for diseases such as neovascular AMD. Here, an example of an en-face OCT again with a tangle type 1 neovascularization surrounded by a dark ring in section A. Section B shows a halo around it, as we're used to seeing it on a fluorescein angiogram, and this is usually or commonly described as fibrin, a product of exudation from the most immature vessels at the rim of the neovascularization, producing a shadow on the angiogram. And there's also a dark area here around the neovascularization on the OCTA en-face image. And the structural OCT shows subretinal fluid on top of or in front of a neovascular complex. Now, here we have, to the left, a fluorescein angiogram, in the middle, an indocyanine green angiogram, and on the right, we have a structural OCT, a cross-section, showing with yellow arrow a type 1 component, with a green arrow a type 2 component. Between them, we have remains of the pigment epithelium, and the white arrow shows something that we can't really tell what is, but it would be nice to find out if it is new vessels. And so here are some examples of how the selectivity for a given layer can produce different OCTA images, which you have to the left. So if you go to the right column and 2 images down, you will see a layer that is selective. Where there are 2 red lines that have been made so that they follow the contour of the pigment epithelium, and then on top they have been shifted upwards a little bit to produce an image of that specific layer a bit away from the retinal pigment epithelium. And then if you go to the lower 2 images on the right side, you see how deeper layers are being selected and how they produce different patterns of neovascularization on the lower left side. And here, a similar manipulation, again, from the same eye, in an attempt to show neovascularization that is on top of the retinal pigment epithelium, type 2, and behind the retinal pigment epithelium, type 1, over to the left. And they show very, very different patterns of branching. One spreading centrifugally, the other being tangled and confused. And consequently, there's a lot to learn, and you will understand immediately that when you try to follow patients during the course of treatment, you will have a challenging task here by finding out whether things are regressing, expanding, stable, exuding, or becoming more dry. So you're getting a lot more information about neovascularization in the macula. Diabetic retinopathy is also of extreme interest. And the lesions that we know from high-resolution fluorescein angiography can all be seen except one thing: you can't see leakage with a non-fast OCTA as we have it here, but the microaneurysms, the vascular loops, the non-perfusion, the neovascularization, the expansion of the foveal avascular zone, the venous beading, and the multiple capillary beds can all be seen. And here on the next slide, we have an example of how progression from mild to moderate, severe, and proliferative diabetic retinopathy looks, not in one and the same eye, but in 4 different eyes that are representative of these categories. And the next slide here is 2 sections from the same eye, and these demonstrate the layer selectivity. So to the left, you have the deep capillary, the posterior capillaries of the neurosensory retina. To the right, you have the same section of the retina, but now it's the inner capillary layer that you're seeing. They are both abnormal in different ways, and this is a whole new field of research that is opening, because previously, in a research project, you may have done repeated fluorescein angiograms on a rare patient, but there was an ethical and logistic boundary to how often you can follow a given capillary. Now you can do an OCT angiogram and follow every single capillary from month to month, from year to year in your patients with diabetes. And there is an entirely new endpoint here for following the early stages of diabetes and diabetic retinopathy in a manner that we have never previously had access to. And it's going to be interesting to see how it can change diabetology perhaps, and help us prevent the sight-threatening stages of diabetic retinopathy from threatening our patients. And obviously you're thinking about, what about pre-retinal vessels? Well, here's an example of fibrovascular proliferations in a person with diabetes in front of their retina. And here is the outer layer of neovascularization. There's so much fibrosis, you might think there's not even a perfused vessel there anymore, but yes, there is. And here, the deep layer, and here, the connection between the two and an indication of where you are. And in summary, so OCT is superior to fluorescein angiography in type 1 and occult CNV, and more consistent than ICG in showing CNV patterns in type 1 CNV. It can map capillary damage in diabetic retinopathy in great detail. It can single out the 2 layers of capillaries. It's useful for frequent follow-up. And there are new perspectives for proliferative diabetic retinopathy detection and surgical planning. Thank you.